for small intestine.
Which goes with the stomach, which we
Assalamualaikum warahmatullahi wabarakatuh. My name is Wan Nur Ilham Irdina with metric number 2017672, and I am the first presenter for Group 1. Our group will be presenting on a topic about peptic and gastric ulcers. What is gastric and peptic ulcer? Peptic ulcer is an open sore on the inside lining of the stomach or the first upper part of the small intestine or the duodenum, while gastric ulcer is an open sore in the stomach, which also called as the stomach ulcer. There is actually a thick layer of mucus that protects the stomach lining from the acidity of digestive juice. Due to many factors, the protective layer may be reduced, which allowing the stomach acid to damage the tissue and create these ulcers. Both peptic ulcer and gastric ulcer can be caused by the Helicobacter pylori bacteria or non-steroidal anti-inflammatory drugs, NSAIDs. The regular use of certain pain relievers, for example, when taking aspirin, as well as certain over-the-counter and prescription pain medications called non-steroidal anti-inflammatory drug, NSAID. This can irritate or inflame the lining of your stomach and small intestine. The example for NSAIDs are ibuprofen and also naproxen sodium. This disease also can occur if a person has a rare condition called Zollinger-Ellison syndrome, gastrinoma. This condition forms a tumor of acid-producing cells in the digestive tract. These tumors can be cancerous or non-cancerous. The cells produce excessive amounts of acid that can damage the stomach tissue. Next, we will move on to the natural progression of the disease, which consists of the pathogenesis, symptoms, risk factors, complication, and also the diagnosis of the disease. The pathogenesis of peptic ulcer disease may be considered as a combination scenario involving an imbalance between defensive factors and aggravating factors. Other than that, NSAIDs also play an important role in the pathogenesis. The pathology can be divided into three broad categories. The first one is Helicobacter pylori positive, the second one is Helicobacter pylori negative and non-NSAID associated, and the third one is NSAID associated. The Helicobacter pylori bacteria can cause the inflammation in gastric mucosa with the induction of epithelium-derived cytokines, predominantly interleukin-8 and interleukin-1 beta. The influx of neutrophils and macrophages into gastric mucosa simulates the immunopathogenic process of the ulcer formation. The alkaline ammonia produced by the bacteria will inhibit these cells in the glands from sensing the true levels of acidity, causing an inappropriate release of somatostatin and hypergastrinemia. The ureas catalyze the production of ammonia and leads to an impaired phospholipid layer in the mucosa. Helicobacter pylori colonize the duodenal epithelium with the metaplasia, and after the colonization, inflamed duodenal mucosa becomes more susceptible to peptic acid attack and ulceration. In the second condition, the ulcer can exist in absence of Helicobacter pylori infection and non-NSAID group. Zollinger-Ellison syndrome, truly idiopathic ulcers, Cushing's ulcer, and high-dose upper abdominal radiotherapy fall under this category. The third pathology, which is associated to NSAID, can occur due to suppression of gastric prostaglandin synthesis, cyclooxygenase, COX1 and COX2 inhibition. More so of COX2 is supposed to cause the gastric ulcers. NSAIDs inhibit nitric oxide and hydrogen sulfide, which are responsible for maintaining the integrity of the gastric mucosa. The symptoms that may be shown by this disease are burning stomach, which is actually common, feeling of fullness, bloating and belching, intolerance to the fatty foods, heartburn, and feeling nauseous. Stomach acid makes the burning stomach pain worse, as does having an empty stomach. The pain may be worse between meals and at night. And actually, most people don't even have these symptoms. I think that is all from me. Thank you, and I will pass to the next presenter.
Now I will continue the presentation. The risk factor of peptic ulcer are common in people that have untreated stress, consume a lot of spicy food, and regular use of non-steroidal anti-inflammatory drugs. Smoking, especially in person who infected with Helicobacter pylori, as well as drinking alcohol. This factor basically will increase the amount of stomach acid. Regardless of that, this factor alone does not cause ulcers, but they can make the ulcers more difficult to heal. The untreated peptic ulcers may result in internal bleeding, which will then lead to anemia, and severe blood loss may cause black or bloody vomit or black or bloody stools. Peptic ulcers also can cause a hole in the stomach wall, thus increasing the risk of abdominal cavity infection, which is also known as peritonitis. Next, peptic ulcer can block the passage of food through the digestive tract, causing a person to become full easily, vomit, and lose weight. Based on a study, it was proven that people infected with Helicobacter pylori have an increased risk of gastric cancer.
Next, I will continue with the diagnosis of peptic ulcer disease. Firstly, we should know that PUD is diagnosed using a medical history, physical examination, and invasive and non-invasive medical testing. A thorough history should be taken, and any difficulties should be documented. PUD is suspected when patient experience epigastric stomach discomfort, early satiety, and fullness after a meal. Gastric ulcers cause weight loss because the pain increased 2 to 3 hours after a meal. But duodenal ulcer cause weight gain since the agony lessens after a meal. Any patient who has anemia, melena, hematemesis, or weight loss should be evaluated further for PUD problems such as bleeding, perforation, or malignancy. During a physical examination, tenderness in the epigastric area and symptom of anemia might be discovered. For further discussion, we will discuss a few diagnoses and investigations that can be done for peptic ulcer disease. First is esophagogastroduodenoscopy, which is EGD, also known as the gold standard test and most reliable diagnosis test for identifying gastric and duodenal ulcers, with sensitivity and specificity of up to 90%. Patients over the age of 50 who are experiencing new dipeptic syndrome should get an EGD. Regardless of age, anyone experiencing alarm sign should get an EGD. When EGD is not an option, barium swallow is considered. It is an esophagram imaging examination that examines for issue in the upper GI tract. Fluoroscopy is a sort of X-ray that is used in this examination. Chalky testing fluid containing barium, which is a chemical that enhances the visibility of bodily components on X-ray, is also consumed as the part of the test. Other than those two tests, complete blood tests, liver function tests, and amylase and lipase levels are also recommended. If Zollinger-Ellison syndrome is suspected, a serum gastric test is conducted. Besides, to detect Helicobacter pylori, numerous tests can be done, such as serology tests and urea breath tests. Serology tests are the tests performed to determine whether or not a bacterial infection is causing stomach ulcer. The serology test involves looking for the antibodies to Helicobacter pylori in the bloodstream. A breath or stool antigen test should be used to confirm a positive antibody screen. Other than that, urea breath test is high sensitivity and specificity. It may be used to confirm eradication after 4 to 6 weeks of stopping treatment. In the presence of urease, an enzyme produced by Helicobacter pylori, the radiolabeled carbon dioxide produced by the stomach is exhaled by the lungs. Other than two previous mentioned tests, stool antigen test, urine-based ELISA, and rapid urine test, also endoscopic biopsy, also can be done. Basically, endoscopic biopsy is typically disapproved even since it is costly, time-consuming and intrusive, but at certain conditions, it can be used to enhance the sensitivity. Lastly, the use of computerized tomography of the abdomen with contrast in the diagnosis of PUD is limited, but it is useful in the detection of complications such as perforation and gastric outlet blockage.
Now I will talk in detail about the pharmacotherapy of gastric and peptic ulcers. The first one is antacid. Antacid used for prompt symptomatic relief of peptic ulcers disease and GERD, as well as neutralizing existing stomach acid and provide rapid pain relief. It also promotes ulcer healings by neutralizing the hydrochloric acid and reducing pepsin formation. There are two types of antacid which are systemic, for example, sodium bicarbonate and calcium carbonate, and the second type is non-systemic, such as aluminium or magnesium hydroxide. The side effect can include constipation or diarrhea, depending on the main ingredients. Antacid can lower the drug absorption of other drugs, so it is recommended to give other medicine after 1 to 2 hours. Next is antimuscarinic drug, for example, pirenzepine and talenzepine. So here is the mechanism of action of this drug. Firstly, it selectively blocks M1 muscarinic receptor. Then, vagal stimulation will be decreased. This action inhibits gastric secretion, thus leading to decrease in pepsin secretion. The side effects of this drug are dry mouth, blurred vision, tachycardia, photophobia and minimo. H2 receptor blockers also can be used to treat gastric and peptic ulcers. It is a reversible competitive inhibitor of H2 receptor only. It acts by inhibit CYP450 mainly with cimetidine and least with famotidine. Drug use are cimetidine, famotidine and ranitidine. All of these drugs should be taken orally and pass through first phase effect. H2 receptor blocker uses to treat peptic ulcer, GERD, and non-ulcer dyspepsia, as well as to prevent bleeding due to stress-related gastritis. The side effect includes headache, myalgia, diarrhea, and confusion. It is advised to not use H2 receptor blockers drug in pregnant women. It should be noted that cimetidine can cause impotence and gynecomastia or galactorrhea in men.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Amruddin bin Abu Bakar. So I will continue the presentation by explaining about the pharmacotherapy of gastric and peptic ulcer. Number 4, we have protein pump inhibitors. PPI is the most effective therapy in anti-ulcer therapy. It is an irreversible inhibition of hydrogen ion and potassium ion ATPase in parietal cells. The dose of administration is mainly once daily. The drug used, for example, are omeprazole, esomeprazole, and pantoprazole 4. Avoid long-term use as it has a high risk of infections such as pneumonia. PPI is very useful to treat gastroesophageal reflux disease as well as PUD. The usage of PPI may trigger adverse effects such as diarrhea, headache, and nausea. Moving on to the prostaglandins. Prostaglandins is used for inhibits the acid secretion and promotes mucus and bicarbonate secretion, reduce the incidence of non-steroidal anti-inflammatory drugs, induce ulcers by 50%, and protect against NSAID peptic ulcer disease (PUD). It is usually used with multiple doses. The side effects prostaglandins are diarrhea, abdominal pain, and it may also contribute to contraindicated in pregnant women, increased uterine contraction. The sixth one, we have mucosal protective agents. Under mucosal protective agent, we have sucralfate and bismuth subsalicylate. Sucralfate is a salt of sucrose complex to sulfated aluminum hydroxide which able to form a protective layer and stimulate angiogenesis for healing. Gastroenteritis and stress ulcer are examples of diseases which need sucralfate as their treatment. The most common side effect of sucralfate is constipation. Avoid long-term use as it will increase risk of nosocomial pneumonia infection. The second one, we have bismuth subsalicylate. It's able to inhibit the pepsin activity, increase prostaglandin production, and direct antimicrobial activity against Helicobacter pylori. Bismuth subsalicylate most common side effects are darkening of stool or tongue and severe constipation. The last one, we have antimicrobial agents. Under antimicrobial agents, we have gentamicin and tobramycin. Gentamicin may inhibit bacterial protein synthesis by binding to 30S ribosomes. It is very helpful to treat several types of bacterial infections, including bone infections as well as meningitis. The side effect of gentamicin includes nausea, headache, and joint pains. While tobramycin, binding to a site on the bacterial 30S and 50S ribosome, preventing formation of 70S complex, also binds to RNA aptamers, artificially created molecules to bind to certain targets. It is very useful to treat eye infection and gram-negative infection, especially Pseudomonas. The side effects of tobramycin are diarrhea, pain at the injection site, and also headache. Refractory disease and surgical treatment. If a patient is insensitive to medical treatment or at high risk of consequences, surgery may be recommended. A refractory peptic ulcer is one that is larger than 5 mm in diameter that does not heal after 8 to 12 weeks of PPI treatment. Persistent Helicobacter pylori infection, ongoing use of non-steroidal anti-inflammatory drugs, or major comorbidities that impede ulcer healing or other disorders such as gastrinoma or gastric cancer are the most prevalent reasons. Vagotomy or partial gastrectomy are two surgical alternatives. That's all from me. Thank you.
Lastly, as we know the risk factor of peptic ulcer before, here is the list of prevention that we can practice. First, cut caffeine. Second, eat smaller meals. Third, avoid non-steroidal anti-inflammatory drugs. Fourth, reduce alcohol consumption. Fifth, avoid lay for 2 to 3 hours down after a meal. Sixth, manage stress. And lastly, avoid fatty, fried, spicy, or acidic foods.
In conclusion, peptic ulcers and gastric ulcers are both caused by a weakening layer of mucus that serves as a barrier to stomach acids, enabling these acids to penetrate the lining of the stomach and cause an open sore that may bleed. The agent that can induce this condition is Helicobacter pylori, which induces an inflammatory response in the gastric mucosa, primarily via the production of interleukin-8 and interleukin-1 beta in the epithelium. Among the symptoms are burning and pain in the stomach, constipation, bloating or belching, intolerance to fats, heartburn, and nausea. It is crucial to treat this condition as many complications may happen if it is not treated, and this includes internal bleeding, a hole in the stomach wall, blockage, and even gastric cancer. Next, as for pharmacotherapy, these conditions can be treated with drugs such as antacids, antimuscarinic medications, and H2 receptor blockers like cimetidine. Treatment for peptic ulcer disease may also include histamine receptor blockers and proton pump inhibitors. For patients who do not respond well to medication or who are at high risk of side effects, a surgical procedure like vagotomy or partial gastrectomy will be recommended. Moreover, to prevent peptic ulcers, smoking, drinking alcohol, and eating spicy meals must be avoided. Lastly, I'm going to present on the Islamization on this topic. The length of time spent fasting may have an impact on the development of ulcer disease. Islam advises people to get up early for sahur and break their fast as soon as possible in order to prevent this situation from happening. It was narrated from Anas bin Malik that the Messenger of Allah (SAW) said, "Eat sahur, for in sahur there is a blessing." It is essential to wake up for sahur in order to prevent the stomach from emptying during fasting and to enable the gastric acid to break down the food particles rather than the stomach lining. According to Dr. Razrim, fasting is not a concern for patients suffering from this disease. However, if people are experiencing severe symptoms, it is recommended not to fast, since Islam would never burden its adherents, as being said in Surah Al-Baqarah verse 185, in which Allah said, "Ramadan is the month in which the Quran was revealed as a guide for humanity with clear proofs of guidance and a standard to distinguish between right and wrong. So whoever is present this month, let them fast. But whoever is ill or on a journey, then let them fast an equal number of days after Ramadan. Allah intends is for you not hardship, so that you may complete the prescribed period and proclaim the greatness of Allah for guiding you, and perhaps you will be grateful." Thus, the fasting prescription evolved throughout time. To begin, God granted the believers permission to break their fast. Then, God made the fast mandatory unless there was a solid reason to abstain. That's all from our group. Thank you.